Hello everyone, and welcome to this review. It's that time of the block again. You're about to get into your clinical skills assessment, and I just wanted to do a quick review of your documentation and also of efficiency during your clinical skills encounters. Apologies for any of the noise in the background. It's just my radiators clanking because, it's April in Chicago. Okay, so what I wanted to familiarize you with is a history-taking template that I like to use whenever I'm seeing a patient. Now, this is something that I have used for my own purposes, so you're welcome to try it. You're also welcome to edit it to suit your own needs. What I've been noticing is that, first of all, you guys are doing a phenomenal job with your clinical skills acquisition, and I know this because you're doing well in your CSAs. I'm getting a lot of great feedback from the preceptors. In fact, they're telling me that you are way outperforming your predecessors. I'm very pleased to hear that. And thirdly, I know this because of the questions I'm getting from you all. Your questions are about things that I normally consider much higher level clinical skills, such as pertinent positives, pertinent negatives, how do I document appropriately. So I'm happy to see that you are thinking along the lines of really someone who's a clinician expert or coming towards a diagnosis. So hopefully I'll give you some tips today that might be of use to you. Okay, so in your packet this time for preparation, you will have this template. And again, this is what I use and I'm going to walk you through it. Please feel free to edit, amend, try it out if you want to or not, if you don't feel like this is useful to you. So when I'm about to get into a patient's room, either a standardized patient encounter or a real patient in real life, first I take a look at the instruction sheet, or in my case, at their chart to see what they're coming in for. And I jot down their name and their age. So, your encounter is really a test of your clinical skills. And in fact, your history taking and your physical exam during that encounter, you're using to test your hypothesis. And for me, my hypothesis starts with the chief complaint, and their age is part of that reasoning process, because that can actually help me determine what sorts of disease processes I may be looking at. So I start with their name and age, and then I'll write down the vitals, because those are always given to you in your encounter, and then I'll write down the chief complaint, because that helps me think about what differentials I might be looking at. So I'll jot down what are some things that I might be thinking about as soon as I see the chief complaint. And then I write down what are my cannot miss diagnoses for that specific chief complaint. And the reason I write that down is because I know that I must remember to ask these questions during the encounter, and that will help me with my pertinent negatives and positives. So as an example, if someone comes in with fever, I must remember to ask about recent travel abroad, and I must remember to ask about sick contacts. And that's where vitals might be important, of course, because this might be a septic shock. And if that's the case, my history and physical exam will be very truncated during that encounter because I need to move on to management very quickly in that scenario. Whereas if someone with fever is something chronic and they're looking well and their vitals are otherwise stable, I can take my time in figuring out what their problem actually is. Okay. So then I jot down some of the things I'm looking for in the HPI. So in a pain patient, I must remember to ask the QRST questions, always ask how this is affecting their life, and always ask what they think is going on. This in particular is useful to help you address whatever anxiety the patient's coming in with. And those are important to address in addition to the organic illness that you're trying to figure out and manage. Associated symptoms. So sometimes these are things that they tell you about that you might not have enough knowledge yet to put into context, but you know they're important and so they should be documented. And then the pertinent positives and negatives, like we talked about, that's you testing your hypotheses. So is it differential number 1, differential number 2, differential number 3, or something else? Now, when I'm asking about past histories, I've created a mnemonic for myself that I always ask every patient. I created this many years ago, and so I've gotten into the habit of using it. You may create a different mnemonic or whatever is useful to you. And so I always ask every patient if they've ever had a history of tuberculosis, high blood pressure, rheumatic fever, etc., etc. And I jot those down as I go. Of course, it changes based on the disease process that I'm working with too. For medications, this is very second nature to me at this point, the drug dose, route frequency, and any reaction to medications, mainly because I prescribe, and in order to prescribe, you have to know that detail. You guys are not prescribing yet, so it may not be second nature to you to ask these questions, so you may want to jot that down in your template. Must ask about. Okay, and then social history, always, these three things are always part of your social history. Do you smoke? Do you drink alcohol? Do you do any illicit drugs? Have you ever done any of those in the past? The review of systems is something we haven't talked about yet in much detail. You have probably seen it in your cases so far. We do ask this. This is not your responsibility just yet, but it will be something that you will come across in the near future, and will be responsible for asking all your patients in the future. So I just tend to jot down all the things that I think I'm going to have to ask, and I cross through them as I make my way through. In the physical exam, well, the vitals you probably already have jotted down from your instruction sheet. Here I like to write down the things that I found that are relevant, the things that I found that were not present or no abnormalities when I was expecting to see them. So for example, in a heart failure patient, I'm looking for an S3, a JVD, dependent edema. If I don't find a JVD, that's important for me to write down as a partner negative, because maybe that affects my eventual diagnosis. Now here's one I made earlier. So you can see it better. Apologies for the chicken scratch. This is how you know I'm a doctor. Welcome to your future. So this is how I use my template. So I wrote down the name and age. This is Mrs. Jones, who's 58 years old. These are her vitals. This is important to me because it's abnormal and she's presenting with chest pain. In someone with chest pain, these might be some of the diagnoses I'm looking at. And then I should think about the cannot misses. And what I've written here are some questions to ask associated with those. So remember to ask about exertional chest pain if I'm looking for an MI. Remember to ask about recent travel history if I'm considering a PE. Remember to ask about recent trauma to the chest wall if I'm considering a pneumothorax, etc. So I wrote all this out before I even met the patient. Then when I went into the patient's room, I remembered to ask all these questions associated with chest pain. At this stage, I can memorize most of these things. You may want to write them down here, of course. I talked about consequences with her, and she described how it's affecting her work life. And her main concern is that it's her heart, because there's strong family history of heart problems. Interestingly, she also had grandchildren who were around her who were sick, and she's also noticed a few herself, so I wrote those down. I asked about positives and negatives, as discussed up here, and they were present. I asked about her histories, and I chopped off the things that I commonly find and were present in her case. I wrote down all the drugs that she was on. I'm very familiar with the common dosages, etc., so I didn't write those down here, but you may need to do that at this point. Got her social history, and interestingly, I found in her review of systems that she had some other problems like frequency, and I wrote down query sugar. In other words, I should make sure to check her sugar because if she's having urinary frequency perhaps or diabetes out of control. On physical exam, I wrote down the things that I found and the things that I interestingly did not find, like edema. Okay, so that's my template. What you will find in the document that you're provided is an example of another template that someone else uses. This we got from a website, and we provide this to some of our M3s who are getting prepared for their Step 2 CS. It looks kind of overwhelming, but if you really read through the mnemonics, so essentially this person has created different mnemonics for themselves. So at the doorway, they write down all of these things. Once they get into the patient's room, these are all different types of things that they want to make sure to ask. And the mnemonics are explained here. This is in your sheet that you've got with you. The website is also mentioned below. So if you go to their website, they've got examples of what this might look like when it's filled out. So this is their version. So they've written out all the details that they were able to elicit from the patient during the encounter. And here's another example. So this is a patient, Mr. Short, who's a 56-year-old gentleman who's hypertensive, presenting with chest pain. These are their details from the history that they found, and these are the differentials they came up with as a result. These were all the things they remembered to examine. So again, this is just another person's version of a template that they like to use in this kind of scenario. Please try them both. Please feel free to edit them to your own needs and interests. You know yourself better than anyone else does. Now, a word for the documentation that we expect of you. This time you will actually be provided with some stems so you can start to prepare your encounter. What I mean by that is, going back to what I said in the beginning, each encounter is really a test of your hypothesis. So if I've got someone coming in with abdominal pain, I'm going to start thinking about what are the types of things I'm expecting in a person with abdominal pain. So what questions should I ask to elicit those problems? So when we grade, all the graders are clinician experts and therefore experts in clinical reasoning. So what they're really looking for in your document is not a checklist of items, but more a justification of your thought process. Okay? And so there's no right answer to the documentation. Certainly follow the guidelines that we give you on how to document and which pieces of the documentation we're asking you to do this time. All of this is graded responsibility over time, and we will provide you with feedback based on what information you provide in your document. In other words, the clinical reasoning that you demonstrate in your document. Please feel free to contact me if you have any questions or concerns. Good luck with your upcoming clinical skills and your summative examination as well. And I wish you the best of luck. See ya.